years ago, he had had an accident in his carpentry workshop, and then he had a nail stuck in his neck. So you send him for just plain x-ray, and sure enough, here's this metal object in his neck. So you can't get an MRI scan. So because of that, he was at the time referred for a CT scan along with a CTA neck, just to make sure there wasn't a vascular etiology either. So this is the coronal view of the CTA. And at first glance, it may just look like a normal CTA, except that here on the patient's left side, there's something abutting the internal jugular vein that seems to be expanding the left C2, C3 neural foramen. And this is another view. This is a sagittal view. You can see the seam lesion here, and it is very mildly contrast enhancing, centrally abutting and displacing the internal jugular. And here's the axial showing the same thing, something run in the state of Denmark here on the left. So differential diagnosis. So when we think about what this lesion could be, with this sort of limited imaging and the inability to get further imaging, generally, given the location, the appearance, we favored a nerve sheath tumor. And there's this question, does the pain being worse at night help narrow the diagnosis, and why? So yes, it does in a way, because pain being worse at night in the setting of this sort of lesion is suggestive of what we usually call biological pain. So pain coming from inflammation of the tumor itself. And as we all cast our memory back to medical school, the body's endogenous steroids are lowest usually in the very early morning, sometime between 2 and 4 a.m. So it's not uncommon that patients with inflammatory tumors complain of pain that wakes them from sleep. And that's actually, even with metastatic tumor for biological pain, we often ask patients that question. So just when we look again, we see this lesion as we described within the neural foramen. The other clue that it's a nerve sheath tumor or something slower growing is that it seems to actually enlarge this neural foramen and scallop the bone edges, which connotes slow growth. So just reviewing the imaging and the key structures, we're talking about a lesion of the C2-3 neural foramen on the left. So we're thinking about the C3 nerve root, just to review again for those that aren't maybe surgical in the room or aren't directly in contact with this anatomy every day. The first cervical nerve roots coming out over the C1 lateral aspect here, of course, C2 and then C3 in the relevant neural foramen here. So the other thing, just for the surgeons in the room, is obviously we usually are looking at lesions that are within the canal or maybe lateral, but this is a region of anatomy we're not always confronting. We don't always think about the nerve roots this lateral. So the decision was made that this lesion was symptomatic, that the patient wanted it to come out. And so the question is, well, how do you take it out? Because this is obviously a region of the body that has a lot of potential dangers. You have the vertebral arteries coursing through the foramina here. You have obviously the jugular, you have the carotid artery, you have musculature that is between you and this lesion. So the question is always how safest to approach it. There are many approaches to the upper brachial plexus that have been described that involve coming from a more lateral approach, anterior approach, but this high in the neck, based on the fact that we often do anterior cervical discectomy and fusion, and it's anatomy that we're fairly familiar with in neurosurgery and spine surgery, we thought that would be the best approach, to take an anterior approach, very similar to an anterior cervical, but then to take our dissection along the internal jugular and identify those critical structures, preserve them, and hopefully land right at this lesion. So here you see the relevant anatomy, the longus colli, the scalene muscles, and basically this lesion is living right about here. So here we are localizing intraoperatively, just demonstrating that we're at the correct level at C2, C3, and we expect to find the lesion around here. This is with the operative microscope being brought in. So this is, again, this is akin to an anterior cervical discectomy and fusion, except that we're seated more laterally. So here is the medial retractor towards the tracheoesophageal complex, lateral, cranial, and caudal. And this is just a suction pointing to this lesion, this nerve sheath tumor. This is carrying dissection inferiorly, and you're starting to see what appears to be perhaps distal nerve here, unclear in this photo. Here we are debulking the lesion, and you can see it has this kind of fluffy white character to it. This is the nerve stimulator that we were using just to make sure there was no functional distal root. And we'll get to what would be functional in a little bit based on the C3 nerve root. But basically, we're internally debulking this tumor, which has an intraoperative appearance consistent with a schwannoma. This is just further debulking and resection. And then finally, this is a cotinoid within the operative cavity. Here, this is the remaining capsule. We did leave some capsule as we felt that this may be contiguous with a functional rootlet. And then because the nail was finally removed, this is a post-operative MRI demonstrating resection of that lesion. So you can see restoration of normal appearance of the jugular and carotid here. So what are some of the specific risks of this procedure and taking this sort of approach, and what are the potential complications? So as I was alluding to, there are a number of important structures that are in the neck in the region of the C2-3 neural foramen. These include, but are not limited to, the vertebral artery, and also the cervical sympathetic chain lives right in this region. So this is something we were very cognizant of at the time. And obviously, with damage to the sympathetic chain, we would be worried about a Horner syndrome with ptosis, meiosis, and hydrosis. So cast your memories back there as well if you haven't seen this in a while. So, you know, one may be inclined to say, oh, it's C3, you don't have to worry about the arm, but there is a motor function to C3, as we remember, C3, 4, 5, right? Keep the diaphragm alive. And so the other consideration here is hemidiaphragmatic paralysis. So you can actually see this actual patient's chest x-ray following surgery. We got this not because of any breathing difficulty, but we were concerned about this just based on the fact that when we would stimulate that nerve root, we did get a little movement on the left side within the chest, we thought. And you can see that there actually is some elevation of the left hemidiaphragm, and obviously the right is what should be elevated. So this patient did eventually recover a normal anatomical position within a few weeks, but there was elevated hemidiaphragm on the left postoperatively. The pathology in this case was consistent with schwannoma. So just to review, you know, for the sake of being thorough, schwannoma is a benign nerve sheath tumor which arises from Schwann cells. The incidence is about 0.24 in 100,000. There's higher male involvement than females, with peak incidence bimodally in the 4th to 5th decade and the 7th to 8th decade. This is, by the way, this pathology slide is specifically relevant to spinal and nerve sheath tumor schwannoma. Schwannomas do have a higher predilection for the cervical and lumbar spine. They are most common sporadically, but they're also associated with neurofibromatosis 2 and schwannomatosis, which is sometimes referred to as NF3. Both of those conditions are autosomal dominant, and they're due to mutations on chromosome 22. Schwannomas that occur in the setting of NF2 can be more adherent to surrounding structures. But in general, schwannomas tend to be well encapsulated and tend to arise from a single nerve fascicle and displace other uninvolved fascicles. So usually that makes them more amenable to complete surgical resection. Histologically, they have these compact, I don't know if you, hopefully you can see the screen here, these compact Antoni A areas, and then these less cellular Antoni B areas. So this is sort of our board's typical slide appearance for schwannoma. Spinal schwannomas relative to cranial schwannoma tend to have a thicker capsule, a significantly thicker capsule. which we often see at the time of surgery. These tumor cells stain for S100, vimentin, and Lu7, and immunohistochemical staining can show mosaic expression of SMARCB1 in the case of NF2 and schwannomatosis. So this is a way you can differentiate syndromic schwannomatosis from sporadic. And then there are rarer subsets of schwannoma, especially melanotic, have a higher tendency towards malignant transformation. But in general, these are benign tumors. So the other major category of nerve sheath tumor is neurofibroma. These are another tumor, but these arise from endoneurium as opposed to Schwann cells, and they tend to engulf the nerve of origin rather than displacing it. They commonly arise from the skin and the peripheral nerves, less commonly spinal nerve roots, but they do occur there. There's no gender predilection for neurofibroma, and they tend to occur during the 4th decade of life, even if not associated with NF1, which is how most of us think of them. The nerve root of origin in neurofibroma is usually non-functional. So usually patients don't have a focal deficit, but given that investment, it can be difficult to get a gross total resection of all neurofibromas. And classically and primarily, we observe these patients in the population of NF1, which is on chromosome 17, mutation of chromosome 17. But they can also result from sporadic mutations. They tend to be less well encapsulated and are basically a diffuse expansile lesion of the involved nerve. So again, neurofibromas are composed primarily of perineurium, mast cells, fibroblasts, and Schwann cells. The presence of axons on gross pathology distinguishes them from schwannoma, often without the aid of more advanced immunostaining, and they do not have the densely cellular areas characteristic of Antoni A. So this is a pathology image of plexiform neurofibroma, which is one of the mainly observed subtypes of neurofibroma, also cutaneous being one. I guess I flew through that. I probably should have taken more time, but I think it was around 20 minutes. I don't know if anyone has any questions relevant to this case. I'd happily take any of them.
Yeah, Robert, I have a question. McDermott here.
Yes, sir.
If that patient didn't have the nail in his neck from the front, would you have gone from the front or would you have gone from the back?
I think we still would have approached this anteriorly. Now let me go back. Obviously, we did remove, I forgot to mention I'm just trying to go back in the slides. It won't go back. We did remove that nail so we could get a postoperative MRI. The other question is, why not just make it was very easy to get out that nail, right? So why not just take it out and get a better image, make sure this patient didn't have schwannomatosis or other lesions. He didn't have any stigmata of the skin, but may have been worth entertaining. I think probably in this case we still would have approached from the front, based on the attending involved. It seemed more straightforward of an approach than cutting through a lot of muscle to get to the lesion. But it's a totally reasonable approach as well posteriorly.
Yeah, I think peripheral nerve surgeon at our place would have done it. Probably from a anterior lateral approach. Maybe not the same way. She might have gone behind the jugular as opposed to in front of it, but I'm not sure. Because it looks posterior to the foramen on that imaging.
To the neural foramen?
Yeah.
Yeah, at the time of surgery, it was kind of even with it.
Oh, okay.
Maybe that was because we had removed, we had dissected this off, the jugular and the carotid off of it, and it was kind of splaying more forward, but it's totally reasonable. I did a similar lower down schwannoma with Alan Levy at Miami, and And we did what you're saying. We came posterior at that for that lesion to the jugular. But that case was also not very straightforward. So
Yeah.
this is I think it's very difficult, which is why I wanted to present it. It's kind of an interesting location for a schwannoma, but it certainly happens.
Cool.
Any other questions from the group?
Was that a nail gun that the guy got the nail from?
I believe it was a nail gun. I believe it was a nail gun, and actually the nail broke in the nail gun, and that's why it was just the shank of the nail. It wasn't the kind of hub of it.
You'd be amazed how many nail gun injuries there are per year across the country. It's a very dangerous device. I had a guy fall off a ladder and discharge the nail through the left temporal region. And when you did the plain skull x-ray, it looked like the nail spanned the entire cranium. We operated on him, but we shouldn't have. Did an angiogram before, did a craniotomy, took out the nail, but as you would predict in the frontal lobes, he had the classic syndrome of bifrontal leucotomy, unfortunately. So, all right. Well, thanks, Robert. Let's, Italo, you're up with the next case.
Good morning, guys. Thank you, Robert. Great presentation. Yeah, let me see if I can share the screen. Can you see my screen?
Yes.
All right. So thank you very much. Very early in the morning for a great presentation. So this is a clinical case. The case is actually published, so I'll give you the details afterwards. So you can look up all the details in the literally published on Journal of Neurosurgery. These are my disclosures. I have lots of disclosure, but like I say, lots of interest but no conflict, and nothing had to do with this talk, obviously. Okay, so this patient, it's a 14-year-old girl who developed progressive bilateral leg weakness 5 years prior. So when she was 9 years old, resulting in spastic paraplegia. So she has been wheelchair bound for the past 4 years. And it was developing bilateral proximal arm weakness as well. So this young girl was from Bolivia. And of course, in Bolivia, I'll tell you now what the images shows afterwards. Nobody wanted to touch her for this problem. Her picture, the image of her MRI was sent to other centers, and nobody really volunteered to treat her. So there was a missionary center that contacted the voluntary service here, a Baptist, and they presented the case to me. And we brought the patient from Bolivia here to Baptist. So on exam, she has a nevus on the torso. She has spastic paraplegia with sustained bilateral clonus. She has sensory anesthesia at the level of T8. She has a spastic bladder and bowel incontinence, so she's been wearing diapers since she's probably 10 years old. And she's becoming weaker in the upper extremities as well. So she spent most of the time in bed, feeding. Her mom is feeding her. Very poor family from Bolivia. So this is the MRI. And you can see there's a very large vascular malformation. There's also two angiomas in the T8 and T9, and that corresponds to a metamere. She has a nevus on the torso that correspond to the dermatomas for these two sections. And you can see there's massive venous congestion and cord swelling and edema. So what is this? So this is a extradural intradural AVM type 3, also been called metameric or juvenile AVM. If the entire metamere is involved, skin, muscle, bone, dura, and cord, this entity is called as Cobb syndrome. Cobb syndrome was published by Cobb, Hemangioma of the spinal cord, in 1915. described back then. So a little bit of history about this very rare condition. Stanley Cobb described hemangiomata of the spine associated with skin nevi. The diagnosis was made after laminectomy with dural exposure, visualizing a tense, bulging vessels in the spinal canal. It's unclear if the lesion described was a spinal AVM or a complex dural fistula, because we don't have MRI from the 1915, but that's what Stanley Cobb described and remained in literature. Several reports follow with ischemic use of this syndrome because of the absence of angiographic description and MRI description of vascular lesion. And finally, in 2009, it was defined as an entity, as a Cobb syndrome, as an extradural, intradural AVM, which involved bones, muscle, skin, spinal cord, and nerve roots. The number of documented cases of Cobb syndrome in the literature is approximately 40. We went to, the paper was published with co-authorship of Dr. Dabus and our fellow Dr. Samaniego. So we went to a literary research of this entity. Most of the time, interesting, is in the thoracic spine. The diagnosis, MRI and spinal angiography. A spinal angiography obviously provide definite diagnosis. You can see the entire details of the lesion. So what to do in these cases? Nothing. Nobody wants to do anything. Medical management, I don't think there's any choice there. Open surgery usually is not indicated because it's just impossible. You guys can imagine being surgeons. Radiation therapy, then you have to radiate the entire spinal cord. We can discuss, I'm not an expert in radiation therapy by any means, so maybe Michael can discuss at the end what would be the outcome for radiation. And then the vascular embolization, this is what was sent to me. Obviously, it was sent to us, obviously. So, so we took it to angio, and my idea was to evaluate the lesion from an angiographic standpoint, and perhaps that was I had no intention of, treating this young woman, to kind of shrink the lesion because she was getting weaker in the upper extremities as well. She had like a proximal deltoid weakness and with brisk reflex in the upper extremities as well. So she was getting, the cord, of course, was getting more and more congested. So this is the angiographic appearance of this monster AVM from the left TA. You can see the massive venous congestion of the spinal cord. You can see the azygos even filling afterwards. So this is a myocardial angiography. I selected the feeder of this AVM. In these cases, it's never really, I didn't find any report of embolization of a Cobb syndrome. So, but my idea was to treat like another AVM, other AVMs that we do. So we do in several sessions. I didn't want to embolize the whole thing. So this is what I found from this section by myocardial. You can see my myocardial feeding right into the AVM, and the AVM is everywhere. It's not just spinal cord. Is everything, extradural and intradural. So this is after embolization of this section, and you can see the angioma of the T8 here. So with good result, you can see the onyx cast here in the section of the AVM. And then we went to T9. On T9, you can see the anatomically and hypertrophic arteria radicularis magna, or artery of Adamkiewicz, that feeds straight into the AVM. She's paralyzed, so, but of course I didn't want to occlude the Adamkiewicz. So I selected the Adamkiewicz with microcatheter. You can see a microcatheter here, all the way into the AVM until I found some kind of a safe landing zone away from the artery of Adamkiewicz. And this is the onyx cast, injected onyx. You can see the onyx cast, very interesting. I can imagine, obviously, connects with the onyx cast from the previous injection, because of course it's the same thing. And then went to, from T8, you can see the feeder. You can see the classic nasal vessel in a big hypertrophic vein feeding to the perimedullary venous plexus. And this is, of course, I selected very, very distally the AVM with a microcatheter. These are, you can see the artery is slightly bigger than microcatheter, and we do this all the time, Dr. Dabus and I. We select these very tiny vessels. It's slightly bigger than we used to. They usually are not that big, obviously. But that's before and that's after embolization. And then another section of the AVM was fed by the T6 metamere radicular artery. And you can see beautifully, that's typical features of a spinal AVM feeding artery, the nidus and its big hypertrophic vein and congestion of the perimedullary plexus and other veins too. So, but at this point, what I've noticed during the case that there was the feeding of the veins was much slower than at the beginning of the angiogram. So I really, a little bit of freaked out because I was thinking, if she, and we see this when Guillermo and I and all the guys that do endovascular, when embolize a big AVM, at a certain point, you can see slow filling. As of course, the flow into the nidus gets slower. You can see very slow filling of the veins, the outflow veins. I always get a little bit worried that the vein might thrombose and the AVM might explode. So at this point, and also she could have like a massive cord infarction because this AVM affects a large section of her thoracic cord and become quadriplegic. So I stopped at this point. I stopped. I said, I think we did a enough job, but let's see what's happening afterwards. So patient woke up, she was okay. And day after, she told us she started feeling her legs for the first time in 4 years. And I didn't know what to make of it because I would never expect that. But then I was really shocked when 2 days later, she has a minimal proximal movement in her lower extremities, mostly in her feet. And 1 month later, she was kept here for physical therapy. She was able to make some steps at the parallel bar with support. Everybody was shocked about it, including the therapist, of course, myself. So at this point, then I took her back to angio. I went to T6, that was the one I was embolized. The veins were filling a little bit on a faster mode. And that's the beautiful angiographic images of the selective myocardial injection of the AVM. And you can see just before and then after embolization, the AVM is gone. So then I did a full angiogram, spinal angiogram from T8, remember the one I embolized before, and then there's nothing here. You can see the onyx cast. T6, you can see Adamkiewicz is still there, angioma on the vertebral body. And then T8, there's no AVM, and T6, of course, no AVM. So that's the MRI before, and that's the MRI after. So basically, I didn't see anything. So cure by embolization of Cobb syndrome. And that's her. So we brought her back 3 years later. After she went back to Bolivia, 3 years later, I saw her able to ambulate by herself for short periods of time. Otherwise, she mostly used a walker. She has normal bladder and bowel function. And on exam, she has a Brown-Séquard syndrome. So we turned a spastic paraplegia into Brown-Séquard. And to my amazing surprise, she has a normal spinal angio. So the AVM is cured 3 years later. So Brown-Séquard, you might remember, all the neurologists know this very well. You might remember, everybody. It's an area of cord damage. So she probably, from her massive congestion, what she's left with an area of damage. It's not a complete Brown-Séquard, but she had lost of pain and temperature on one side and loss of motor function, mostly on the right leg. It's not completely paralyzed, but it's definitely is weaker than the other leg. So we published a paper on, we put all the images together and did a review. Guillermo and our fellow Samaniego helped us a lot. It was published in JNIS 2012. So briefly about, I don't know how much time I have, Cobb syndrome. So what about treatment for Cobb syndrome? Initial surgical intervention with or without radiation therapy was published in 20 to 42 cases. Because of high complication rate, surgical treatment has been abandoned. And it's been abandoned only for type 2 spinal AVM, which is the true spinal AVM. People don't tend to do, unless, I don't know, maybe Dr. McDermott can, but to my knowledge, don't really think to do surgery for those. So conservative treatment was performed in 6 to 42 cases. So traditionally it's been thought that endovascular therapy, since a type 3 spinal AVM is a very large nidus, curative therapy might not be possible. So the first case ever described of cure of a type 3 spinal AVM. Definitely should be considered, I think, after this report and other reports for type 2, embolization for type 2 spinal AVM as a cure is successfully done, should be considered at least. So endovascular therapy of spinal dural fistula, then that's a more accepted mode of treatment for type 1 spinal AVM. It's been described as possible cause of paraplegia, but not for spinal AVM. So, and actually we had a couple of cases here, Dr. Booth and myself, for patients. They were not completely paralyzed, but they were able to solve their paralysis. But these are dural fistula. There was a great case that also Italy, Dr. Siomin, I don't know if it's in the audience, I'll never forget, it was a patient that just came with weakness and then became paralyzed in the hospital. We did the angio, and because it was close proximity to the Dankiewicz, and she went for surgery, and Vito operated on this patient, and he was paraplegic, just like a few hours before, and he recovered completely. So it's for spinal dural AVF, recovery from paraplegia has been described, both for endovascular therapy and, of course, classic traditional open surgical approach. 70 patients with intramedullary AVM had overall improvement in neurological function status in 14 patients after onyx. However, on these cases, case description, only one patient had severe paraparesis pre-embo, and despite complete obliteration of the AVM, her motor function did not improve. And that was published in Journal of Neurosurgical Spine in 2007. So the first report of improvement or resolution of paraplegia after type 1 spinal AVM. So this is a dural AVM by endovascular embolization was published by De Costa and Bruges. There was an old paper, 47 cases. And in excellent outcomes, not everybody improved, but most of them improved, 45, almost 50% improved. And in our cases here, they all improved too. But they were not paraplegic. I think one patient that Dr. Siomin operated on, he was paraplegic. So we had a case of recovery from paraplegia after a treatment of a dural fistula. So I'm done. I did it pretty fast because I know you guys, it's kind of early. Maybe it's time for questions. So endovascular embolization of spinal AVMs, I think it should be considered. I think it's possible, especially with type 2 spinal. For dural, we can discuss. For dural AV fistula, I think surgery is a pretty good approach. I mean, I'm an endovascular guy, so I recognize that it's a pretty good approach for, especially in patients in which there's close proximity to a Dankiewicz. I mean, we can take the artery Dankiewicz and catheterize it, but of course it's something we don't do lightheartedly, obviously. And if there's a possibility of avoiding that, of course, none of us want to do that, and neither Dr. Booth and myself on most of the interventions in the country. So if the lesion is approachable surgically, we're talking about dural fistula, type 1 fistula, then I think surgery is a great option. I mean, please don't get me wrong. I'm not one of these guys who want to endovascular for everything.
Thank you so much. This is really great. I just wanted to echo that I actually really appreciate you saying that about surgery in type 1 dural AVF. We just put out a paper actually on reviewing 6 cases of basically revision surgery following endovascular therapy for type 1s. And it makes the surgery becomes more difficult when ultimately the success rate is pretty excellent, as most of us know, with just simple disconnection of type 1 fistulas. So I really appreciate that sentiment, and I think it's, just honest and really, really great.
Thank you. No, yeah, of course. I mean, I think if it's a clean shot, then there's no arteries that are, eloquent. Let's say eloquent for the spine. The spine is not eloquent. I think Guilherme and I we've done it. But in this case in which there's a little bit, and we know, and Guilherme and I know very well, during embolization, even if you don't have a direct anastomosis with anterior spinal artery or posterior spinal artery, they can develop. As you embolize, they can develop. And that's something that, we have seen it in other cases. So we don't want to do that. And onyx is a little bit tricky to control. Perhaps glue is a little bit easier, but of course, if it's a clean shot for endovascular, that's great, great results, amazing results. But if there's some doubts, no question, we call you guys, and you guys do a fantastic job. So I'm one of these guys. So I was just when I finished, I think the treatment of rupture or non-rupture type 2 or type 3 spinal AVM is definitely possible. I have a great, actually, I don't know if Dr. McDermott, I have a great talk on that. I reviewed all this literature on the spinal AVM. Maybe we can do it one of these days. It's possible endovascularly, especially with type 2 spinal. I mean, it's not easy, obviously. Not it is to take lightheartedly. It's pretty, it requires a considerable amount of intestinal fortitude to do these cases, no question about that. But it's possible.
Yeah,
and then remarkable, I'm sorry, Mike, I've just finished and then I'm done. So remarkable recovery may occur. Then myelopathy is interesting because, and we can discuss, I think the spinal cord, for some reason, is very resilient. And probably you guys know much better than me, more considered to the brain. So we can have recovery. I think I'm done. Thank you very much. Sorry, Michael, go ahead.
Hi, Italo. This is Ron Tolchin. Great presentation. I have two questions. One is, did you image the cervical spine, and how do you explain the weakness of the upper extremities, or was that related to the venous congestion throughout the cord? And,
yeah, great question. Yeah, I mean, she had the whole cord was edematous, all of it. So actually, I was surprised that she was not quadriplegic. I mean, all of us were surprised because the MRI. I show you just the thoracic part, but the whole cord is all edematous. You can see on the angiogram the congestion goes all the way up and down. It just
did that improve after the embolization?
Yeah. You saw that. I show you the picture
of the thoracic, right? But cervical,
everything. She was left with a couple of spots here and there of white matter. That's probably this will give us the Brown-Séquard, the partial Brown-Séquard syndrome. Mm-hmm. I think as the cord shrank, there were some areas of damage.
Okay, and that's how she got the Brown-Séquard, you think?
That's how she got. It was not a complete Brown-Séquard. It was because usually the one that they're described, and neurologists know very well to be, the neurologists are very compulsive. You have to be complete paralyzed on one side and lack of sensitivity on the other side. She was not like that. She was kind of a patchy.
Kind of incomplete.
Yeah.
Thank you very much. Great presentation. Excellent.
No, you're welcome. Michael, you want to say something? I interrupted.
Yeah, do you do these under general anesthesia?
Oh, yeah. So that's a great question. And because, yes, go ahead, Michael.
I was going to say, because there are some, I was showing Robert the other day a paper we published on spinal cord hemangioblastomas. And what I used to do with the big ones was I would put a temporary clip on what I thought the feeding artery was, as close as I could get to the surface of the tumor at the cord. And I would wait 4 to 6 minutes, monitoring the motor evoked potentials during the clipping. And I was wondering if you use intraoperative physiology doing these cases, and whether or not you could temporarily occlude a vessel before embolization with a small balloon catheter to see whether or not there was going to be a motor deficit.
This is a great question, and we discuss it in meetings all the time with all type of IVMs, because with eloquent areas, you inject some anesthetics through the feeding artery, and you do evoke potentials or patients awake and see what happens. And I think is a great idea if you can select exactly the artery that goes there and you have a good control, which exactly what you do, Michael. Unfortunately, in our field, I think that sometimes you can, but sometimes you can. I mean, these arteries are super small. They're like a fraction of 1/3 of a millimeter. So putting a balloon is not possible. Injecting some type of anesthetic agent, whatever, the du jour, we have several.
Yeah, that's a problem.
Exactly. I have a problem.
Problematic.
There's so much collateral circulation because this AVM has been there forever that you don't know where this dumping is going. I'm not sure. I mean, if you're really like a straight shot and you can kind of tell, then it's possible. But if it's not, it's a little tricky.
Yeah, but even if you didn't have the ability to temporarily occlude, I think you should be monitoring motor evokes if the patient's asleep when you're doing these high-risk AVMs. I mean, it's a fantastic result for that patient. I never would have predicted that. I would have said that was untreatable, and the risk profile associated with embolization would have been extremely high. But I think you should consider that routine, which is when the patient's asleep, do motor evoked potentials. Somatosensory, don't really care about. actually. And the motor evokes are important because, 2/3 of the cord are in that anterior motor pathway, at least from a vascular point of view, in terms of blood supply to the cord. So I think you should routinely do intraoperative motor evokes when you're doing the EMBO for these cases.
In this case, remember, she was paraplegic, so I don't think we're able to get anything below. Maybe
Well,
above,
yeah, but we published, I think we published it somewhere, where a patient had no movement, voluntary movement, left hand. I was able to generate movement in the hand with cortical stimulation at the time of surgery. So, paraplegic or not, I mean, if there's any function, including sensory, I think I would recommend. Plus, you can monitor upper extremities as well.
Upper extremity would be a good idea. No, but like you said, I would never. My idea was just to close because she was getting worse, and of course, she was become either quadriplegic or she would have ruptured and died from a massive subacute hemorrhage. So my goal was to kind of shrink the AVM. I would never expect my entire to cure this damn thing.
What did you use? Do you use Onyx?
Yeah, I'll use Onyx.
Very good. What time is it? It's 7:46. Any other questions? All right, let's take just a short break. Let's take a 5-minute break. Let's come back at 10 minutes to 8, and then we'll start with Dr. Restrepo. How's that?
Sounds great. Thank you, guys.
Thank you.
Yeah.
Can you hear me? Yeah.
All right, so let's move on to the main portion of the presentation this morning. Dr. Restrepo, one of our physiatrists, is going to be speaking this morning on the role and utility of EMG and nerve conductions in management of patients with back and cervical pain. Andres?
Yes, I'm going to start. Ignella, can you give me the share screen option? Right here. I apologize.
Okay, we're good. We see it.
Oh.
You're on slide 5.
Okay, sorry. That's
no. There
do I switch to regular, Ignella?
No, just do that and then just push the down button on your
Okay,
pad.
perfect. So
yeah, you're good.
Thank you for this opportunity, Dr. McDermott. I'm Andres Restrepo. I'm one of the physiatrists. I joined Baptist Neuroscience Institute 1 year ago, and I'm excited to be here. Thank you very much for this opportunity. We have spoken that physiatry will do a lecture every quarter. So one of my niches is electrodiagnostics. So I wanted to give you a little basics on what we do and what I do at the EMG lab in order for do better patient care. So I don't have any disclosures. These are the objectives. At the end of the presentation, you will have a better understanding about the physiology of electrodiagnostics. We're going to talk about electricity physics and the basics of electrodiagnostics physiology. You will improve your knowledge in when to request an electrodiagnostic consult. You will be able to interpret better a nerve conduction study plus EMG test result. We will talk also about you will improve your knowledge in the EMG findings in the following topics: cervical, thoracic, and lumbar radiculopathies, upper and lower extremities mononeuropathies, thoracic outlet syndrome, and Parsonage-Turner syndrome. So the electrodiagnostic evaluation is considered to be an extension of the neurological examination of the peripheral nervous system. It is commonly used to diagnose intravenous neuropathies, plexopathies, radiculopathies, neuromuscular junction disorders, myopathies, and anterior horn cell disease. What we do in what I do mainly is intravenous neuropathies, plexopathies, and radiculopathies. I leave the neuromuscular junction disorders, the neuromuscular diseases to the neurologists or usually academic centers where they have more patients and more time to do this type of tests that are lengthy. So it can prognosticate functional recovery. It has a role in the localization of the site of the lesion and helps identify the pathology. So what does it include? So the typical electrodiagnostic consultation involves a focused neuromuscular history, physical examination, the examination of muscles and nerves utilized in nerve conduction studies, needle EMG, and the determination of a final diagnosis. This is one of the very important reasons why the referring physician needs to more or less know what they want to look for in the EMG. Sometimes I get EMGs from the primary care physicians. It's like EMG of 4 limbs, you know, but they don't know what they're looking for. So unfortunately, for me, it's more time consuming because I have to do a lengthy physical examination and a history of the patient. So it is converted really, and I do it this way occasionally in a consultation slash EMG nerve conduction study. So this is a very important point. There is an American Academy of Neuromuscular and Electrodiagnostic Medicine, which I am a member, and also the American Academy of Neurology and the American Academy of Physical Medicine and Rehabilitation. These two last ones follow the guidelines of the American Academy of EMGs. So the interpretation and nerve conduction studies without an EMG, meaning the needle part, does not meet its standards and should be the exception in certain situations rather than the standard of practice. And we see this fairly common that we get a patient that had an nerve conduction study, but they did not include the needle EMG part. So this is a typical median nerve. So we have the stimulator here. We have the abductor pollicis brevis pickup and the reference and the ground. And this is what we're evaluating in this case, the median nerve. So the nerve conduction studies, we're going to talk about a little bit of physiology. And this mixes a lot with physics of electricity. So when a nerve is electrically stimulated, the action potential can be recorded through the surface electrodes, and it's termed compound nerve action potential. So when you see CMAP, SNAP, CNAP, those are the terms that we're going to discuss in a second. So the CNAP measures the potentials of large myelinated fibers. Sensory nerves conduction studies are called SNAPs. So are recorded after the stimulation of a sensory nerve. And if it is propagated in the physiologic direction, it is called an orthodromic stimulation. If the impulses are recorded in an physiologic direction, it's called an antidromic stimulation. It's very important to know this when we stimulate the nerves. So this is, when I send you guys the report and you see at the end of all these waves that are electric, you say, well, what is this? So this is a sensory nerve action potential. So as you can see here, we measure the amplitude and the onset latency and the peak latency and the duration. So this is the wave that you see. What in our electrodiagnostics labs, we take in account the peak latency for the sensory nerve action potential. So when you see this, you can see that, this is the sensory nerve action potential. So let's talk about the motor nerve conduction. It measures the compound muscle action potential. The distant latency of the CMAP includes the conduction impulse of the nerve across the neuromuscular junction and in the muscle fibers. There are two responses that we can do with the compound muscle action potential. We can do I'm sorry, I'm going to stop here for view full screen. Just give me 1 second. I'm going to try to switch to full screen so it will be less distracting. I apologize. But I didn't see it here. Stop media and take one control. New share. Just share. Better? Are you seeing the whole screen?
Yes, now it's good. Yeah.
Okay, now it's good.
Yeah.
So I'm gonna let's see if I move this one over here. Let's go back. So talking about the late responses. So we have 2 late responses that we can evaluate during the motor muscle action potential. The H reflex that it was described by Huffman is a result from the activation of the lowest threshold of 1A fibers of a mixed nerve. And the F waves result from the supramaximal antidromic, that's important that I mentioned that before, a stimulation of a motor nerve. I'm going to show this in a second. So the F wave is a long latency muscle action potential seen after the supramaximal stimulation to a nerve. So it is generally accepted that the F wave is elicited when the stimulus travels antidromically. So it's very important for the electrodiagnostician to change the polarity of the stimulator along the motor fibers and reaches the anterior horn cell at a critical time to depolarize it. Then the response is fired down along the axon and causes a minimal contraction of the muscle. It's always supramaximal stimulation. So unlike the H reflex, and I'm going to mention this in a second, the F wave is always preceded by a motor response and its amplitude is rather small. It's usually in the range of 0.2 to 0.5 millivolts. So the H reflex is an electrical equivalent of the monosynaptic stretch reflex and is normally obtained in only a few muscles. Only a gastrocnemius in the lower extremities and the flexor carpi radialis in the upper extremity. So it is elicited by selectively stimulating the 1A fibers of the posterior tibial or the median nerve. So such a stimulation can be accomplished by using a slow, we use less than 1 pulse per second, long duration, 0.5 to 1 meters per second stimuli with gradually increasing stimulation strength. We can see it, we use the H reflex mainly for S1 or C7 radiculopathies. So this is a component motor action potential. If you remember, the sensory was more like a bell floating. This has like a baseline. So in this one, we check the peak, the onset latency and the duration, and that is the amplitude. So remember, with the latency, we measure the myelin of the nerve. With the amplitude, we measure the axons of the nerve. This is very important when we talk about axonal or demyelinating polyneuropathies that are mixed sensory or motor. So when you see all those waves that I sent you, this is the F wave. So as I explained before, it is a small response of the supramaxillary stimulation, and then we usually do 10, and we get the first latency, and that's the F wave. And the H reflex, it's stimulated here, so as we get it, it's the same, the onset latency. So when you see all those waves at the end of the report. So something that I don't do, but it's good to mention here, there is something called repetitive nerve stimulation. This is performed to assess the neuromuscular junction disorders. So they're classified into postsynaptic disorders such as myasthenia gravis, presynaptic disorders such as Eaton-Lambert syndrome, and combined pre- and postsynaptic disorders such as aminoglycoside-induced myasthenic syndrome. So it is very lengthy, time-consuming, and you're not really gonna, it's the last tool that you use to diagnose this type of disorders. I mean, for ALS, you can do some repetitive stimulation as well, and there is a criteria called the Lambert criteria. But in my experience, I've only seen one that, had all the criteria included to really say, you have amyotrophic lateral sclerosis. So this is a repetitive stimulation. You do waves and you see the decrescendo, like right here, of the motor stimulus. So the EMG testing, meaning about the needle EMG, when we put the needle in. So as clarification, when we talk about, I want to do an EMG, it includes both nerve conduction study and EMG. But it has two parts, the nerve conduction study and the needle EMG. So in theory, the electrophysiological signal resulting from the voluntary firing of a motor unit is the summation of the firing of all the muscle fibers within the motor unit, the MUA, motor unit action potential. So I'm gonna show you in a second. So when I put the needle in, the muscle moves, of course, because it's an external stimulus into the muscle and it's a needle. So it's called insertional activity. So spontaneous activity are waves seen in the absence of needle movement or voluntary contraction. So in our report, when I mentioned to you that, there is a spontaneous activity, meaning the muscle is moving when it's not asked to. So the fibrillation potentials, positive sharp waves, complex repetitive discharges, and myotonic discharges are abnormal discharges from a single muscle fiber. And fasciculations, myochemic discharges, cramps, and neuromyotonic discharges emerge from the motor unit. This is important when we're diagnosing myopathic diseases. So this is a motor unit action potential. So it has the amplitude, the phase, it has the turns, the baseline crossings, it has a satellite. So it's a compound potential representing the sum, as I said before, of the individual action potentials generated in few muscle fibers of the unit that are within the pickup range of the recording electrode. So why is this important for clinical practice? So in demyelinating lesions, the compound action potential and sensory action potentials are large, distal to the lesion, and demonstrate slowing, potential conduction block, and temporal dispersion when stimulated proximal to the lesion. In pure demyelinating lesions, there should be no findings of axonal loss on EMG, meaning the amplitude will be perfectly fine. So temporal dispersion and conduction block. So these are two important terms, especially in mononeuropathies of the upper and lower extremities. So this is a normal stimulation. You see that the wave here has decreased amplitude, This is a conduction block that you don't get a pickup of the stimulus. In axonal loss, the CMAP and SNAP, this is the motor and the sensory, amplitudes are reduced with the stimulation of the nerve proximal and distal to the lesion as compared with the contralateral side with relatively preserved latencies and conduction velocities. It's very important to always compare right and left because you can have a patient that has a normal, is symptomatic. You do the EMG of the right lower extremity, their nerve conduction study looks like fairly normal or normal low, and then you compare it to the left side and it is a huge difference. So it's very important to compare it, not only taking account the normal values that we have. The EMG of the muscle supplied by the affected nerve show decreased recruitment followed by the appearance of the denervation potentials. So what is recruitment? When I insert the needle, we talk about insertional activities. So I make the patient contract the muscle to see the recruitment of the muscle fibers. In the chronic stages, reinnervations follows with enlargements of the motor unit size, increased number of the phases and duration. So this is very important, for instance, in radiculopathies. Usually we have chronic radiculopathies with spinal stenosis, but you can have an acute radiculopathy over a chronic radiculopathy. So when we do the needle examination, we can differentiate both a chronic over an acute over a chronic radiculopathy. So the localization of injury. So electrodiagnostic is useful in localization of the site of the nerve lesion, whether it involves the root, the plexus, or the peripheral nerve. The presence of the sensory nerve action potential in an area of sensory loss is indicative of lesion proximal to the dorsal root ganglion or in a central sensory pathway. I explain myself and I will show you in a second. So the dorsal root ganglion is after the root comes out of the spinal cord. So if the SNAPs are normal, but you have the CMAPs abnormal, it's most likely a radiculopathy. So you can see focal conduction slowing or block on nerve conduction studies that can localize a site of entrapment. For instance, and I will talk in a second, the femoral nerve entrapment, the deep peroneal nerve entrapment, the carpal tunnel, the ulnar nerve entrapment, thoracic outlet syndrome. So the distribution of the abnormalities in the muscle tested can also clarify the site of the lesion. The EMG can be helpful in identifying neuromuscular junction disorders, myopathic and neuropathic disorders through the motor unit action potential size, configuration, and stability. So the assessment. So identifying whether a neuropathy is primarily sensory or motor, meaning the SNAP and the CMAP. If it's leg dependent and primarily axonal or demyelinating process can also guide the classification of workup. The EMG can predict the activity of submyopathic disorders. The presence of fibrillations and positive sharp waves in association with short duration indicates an active disease in inflammatory myopathy. They disappear with treatment when you do a follow-up EMG. In ongoing denervation, when you have like a chronic radiculopathy, spinal stenosis, fibrillations, positive sharp waves, decreased recruitment, and polyphasic motor units are present. In chronic denervations, waves and positive sharp waves are minimal and small in amplitude with large size polyphasic motor unit action potentials. So this is when I see when I examine a muscle and I see signs of denervation over spontaneous activity, I always do a snapshot. I send it, I add it to the report that we do. So this is a positive sharp waves going downwards because remember, we're examining something intracellular from the extracellular point. And this is a fibrillation because it's polyphasic. And this is a complex repetitive discharges, needle EMG. This is an acute denervation. They're very typical. So when we put the needle in, we listen and we'll observe. Myotonic discharges are seen in myopathic diseases and myotonia. They sound like a dive bomber. Believe it or not, this needle EMG sounds have very typical sounds. It sounds like a dive bomber, it sounds like boom, boom. It's very typical. So myochemic discharges is due to apoptic firing of the motor unit action potential, seen in radiation plexopathy, MS, syringomyelia, radiculopathy. You can see them like this, like marching soldiers, or it's like, you can hear it. Nerve conduction, so the measurement and prediction of the outcome. So the nerve conduction studies can be an indicator of the severity of a lesion. The larger amplitude of the nerve action potential distal to the lesion, the better prognosis for recovery. The EMG can be a measure of a severity of a lesion. Abnormal spontaneous activity indicates axonal loss. The absence of a motor unit action potential in the muscle supplied by a nerve indicates no action potential traversing the lesion due to either axonal loss or conduction block. So what are the limitations in nerve conductions and EMG? In electrodiagnostic studies, axonotmesis and neurotmesis cannot usually be distinguished, as the primary difference between the two is the supporting structure integrity. Patients with small fiber neuropathies may show normal EMGs as they do not involve the large fibers, which are studied in electrodiagnostic testing. This is one of the big limitations, that we only check the large fibers here. The muscle biopsy is indicated when you're suspecting a small fiber neuropathy. So this is a refresh of the nerve injury classification. We have the Seddon and Sutherland classification. Seddon neuropraxia, 3 axonotmesis, neurotmesis, and Sutherland grade 1, 2, 3, 4, and 5. So in EMG, so in neuropraxia, there is a normal morphology and poor motor unit action potential recruitment, abnormal activity, and goes on the EMG. So I kind of correlate this classifications when I see any findings on the EMG. So another limitation, the EMG of the motor unit action potential can measure only physiologic changes that affect the electrical signal of the muscle fiber and is unable to detect some pathological changes. For instance, in diseases that they have accumulation of storage products like glycogen. So many findings in the EMG testing are sensitive indicators of abnormality, but are not specific for a disease. An example is that fibrillation potentials and positive sharp waves are present in both neuropathic, myopathic disorders, and sometimes even in neuromuscular disorders. So that's one of the good reasons that is very important from the person that is requesting the EMG to see what they're suspecting. So let's talk about something, about the electrodiagnostic of radiculopathies. So we're going to talk about cervical, thoracic, and lumbar. So approximately 60 to 90% of all radiculopathies affect the lumbosacral nerve roots, with the vast majority affecting L5 and S1 nerve roots. Cervical radiculopathies account for only 5 to 10% of all spinal nerve root disorders, affecting the C7, 6, 8, 5 nerve roots in decreasing frequency. To tell you the truth, in my experience, I see more, 5, 7, 8, and 6. Thoracic radiculopathies occur but are rare. They're usually 0.1, 0.5 to 4% of symptomatic disc herniations of the spine. So as the pathology is at the root level, the sensory nerve conduction studies are expected to be normal, given the proximal location of the dorsal root ganglion with the neural foramen. However, abnormal superficial peroneal and sural nerve action potentials have been reported with L5 and S1 root lesions, which may occur with a far lateral disc herniation that impinges the dorsal root ganglion within the foramen. That's why it's important sometimes when you're suspecting it to let the physician know that the patient either has a far lateral disc herniation, so you can mention it in your consultation. So the dorsal root ganglion is right here. We have the sympathetic ganglion, the dorsal rami, the skin to muscle and cartilage, the ventral rami. So this is where the dorsal root ganglion, usually radiculopathies, the injury is right here, the root. So normal sensory nerve action potentials argue for a radiculopathy versus a more peripheral lesion in patients with radiating extremity pain or paresthesias. For instance, L5 or CA radiculopathy rather than a peroneal or coronal neuropathy, respectively. So when we have normal SNAPs, we start thinking about a neuropathy and it's more a radiculopathy. It's important to note that when patients have diabetic neuropathy, that it's actually a mixed, meaning axonal and demyelinating, and mixed, meaning sensory and motor. They can have an overlapping neuropathy over a radiculopathy. That's why it's very important to do both sides, because if you find that they have sensory motor axonal neuropathy, sensory motor axonal and demyelinating neuropathy on one side, you have to compare it to the other side and then do the needle EMG to confirm the radiculopathy. This doesn't happen a lot in the EMG reports that I've seen in the community. So CMAP's amplitude may be reduced by severe axonal lesions affecting the primary nerve root innervation of the muscles used for pickup. For instance, the extensor digitorum brevis, we use it for pickup for L5 radiculopathies during routine nerve conduction studies. In cervical radiculopathies, however, the distal CMAP are not helpful in lesions outside C8 or T1 myotomal distribution. And because as the more commonly affected nerve roots in the cervical spine, RC67 do not innervate the muscles commonly used for pickup in the upper limb. So we use the abductor pollicis brevis for median nerve and the abductor GT minimi for ulnar nerve. The value of the F waves in evaluation of radiculopathies remain limited in clinical practice. F waves are often normal in less severe lesions, but may be abnormal in polyradiculopathies, plexopathies, or peripheral nerve lesions. This, I leave it, there are a lot of articles about this, and it's actually 50-50. So either if it's very delayed, you can't say, the F wave is delayed, so it confirms the radiculopathy, or if it's not very delayed, not to mention it. So H reflexes can be helpful in the electrodiagnostics of S1 radiculopathies. Asymmetrical prolongation or absence of the H reflexes may be present in S1 nerve root injuries with a reported sensitivity of 50% and a specificity of 91%. So if it's negative, most likely no S1 radiculopathy, but if it's positive, it's 50-50. So if you're really suspecting an S1 radiculopathy, it's a good idea to do an H reflex. So the needle EMG remains the most widely accepted method for confirming the presence of a radiculopathy affecting the motor axis. So ideally, and when you see the reports, 6 muscles, including the paraspinals, should be screened for both cervical and lumbar radiculopathies. We have a big limitation here is when I see the patients after they have had spinal surgery, especially in the lumbar area, because in this cervical, usually they're anterior. So when they cut the muscle and, there is there is a scar, usually the paraspinals are gonna show positive sharp waves and positive sharp waves and fibrillation. So usually we cannot use them. In patients with cervical radiculopathy, sensitivities range from 50 to 72%, while sensitivities for lumbocervical radiculopathy range from 49 to 86. So cervical, 50 to 72, lumbar, 49 to 86. So going back to this one, going down to this one, sometimes in the cervical radiculopathy, the only thing that you see positive are the paraspinals. So it's very important. You always have to do the paraspinal muscles when you're doing, when you're diagnosing a cervical radiculopathy. So ideally, the electrodiagnostic should coincide with the development of the denervation potentials, meaning positive sharp waves and fibrillation in the axial and limb muscles. Abnormal spontaneous activity usually first appears in the paraspinal muscles 7 to 10 days following injury, followed by the proximal and then distal muscles several weeks later. And reinnervation follows the same proximal to distal pattern. So this is the $1 million question, is when do I send an EMG to see if I see any changes? So it usually should be performed approximately 3 to 4 weeks post-injury. I prefer 4 to 6 weeks from injury. So how do we diagnose a radiculopathy? So any is needle electromyography. So abnormalities, so needle EMG abnormalities found in 2 or more muscles innervated by the same nerve root but different peripheral nerves confirms the presence of radiculopathy. For instance, L5, tibialis anterior, positive sharp waves, fibrillations. We used to be quadrupeds at one point in evolution. We go to the butt cheeks. So we look for gluteus maximus, L5. If they're both are positive plus the paraspinals, boom, we confirm L5 radiculopathy. As I mentioned before, paraspinal fibrillations or positive sharp waves may be the only electrodiagnostic abnormality found in about 20% with lumbosacral and 40% of cervical root injuries. So remember, the electrodiagnostics is an extension of the physician's history taking and physical examination. Perhaps the best rationale to support its use is establishing whether nerve root injury is present and which roots are affected. It is also useful, as I mentioned before, in situations of suspected acute and chronic disease, such as differentiating an acute radiculopathy from an underlying chronic or radicular process, as may be seen in spinal stenosis. It is also helpful in distinguishing acute radiculopathies from other underlying neurological conditions, such as diabetic peripheral neuropathy, as I mentioned before, which can often obscure acute radicular clinical findings. Remember, the diabetics, when they're long-term diabetics and they do not control the sugars, they develop first peripheral neuropathy, but then they develop what is called a muscle amyotrophy. So they start getting all their muscles atrophied. So if I put the needle there, everything will be abnormal. Electrodiagnostic testing can be helpful in clarifying patient diagnosis when imaging studies are equivocal. MRI scans of the lumbar spine are known to have a high false positive rates, with one study reporting 27% of our normal subjects having a disc protrusion. The false positive rate of MRI of the cervical spine is only 10%, with asymptomatic subjects reporting having a herniated or bulging disc. So relevance to clinical practice, as surgical success rates vary, electrodiagnostic testing can provide objective data to help identify patients who may benefit from surgical decompression. The needle EMG, for example, was reported to correlate well with nerve root injury at surgery in 78.6% of patients based on findings of fibrillations and positive sharp waves in limb muscles in one early study. Another study compared the outcome of patients with lumbar radiculopathy from disc herniations treated surgically to those patients with lumbar radiculopathy treated conservatively, but found that the initial EMG have no prognostic ability to predict outcome at 5 years. So it's better correlated with cervical than with lumbar radiculopathies. Also, these studies showed samples that were small. There were like 15 to 25 patients that didn't have a big sample as well. So for those patients considering epidural steroid injections as treatment for painful lumbar radiculopathy, another study shows that EMG positive radiculopathy had better pain scores and functional improvement after the spinal injection than those that had a negative EMG. In another small study, patients with cervical radiculopathy, those with positive preoperative EMG fare better after discectomy and fusion than patients with normal EMGs. So people sometimes emails me in regards of what are the possible complications of the EMG, what are the contraindications of doing an EMG. I have a patient on an aspirin and Plavix. Can you do the needle EMG? Yes. So complications arising from the EMGs are very rare. So imaging studies performed patients after undergoing needle EMG demonstrated an aggregated risk factor of bleeding of approximately 1% for all muscles with no significant higher incidence in patients or systemic anticoagulations. So it's fine to refer patients that are anticoagulated to do EMGs. The other question is, all those electrical stimulations are gonna interfere with patients that have a pacemaker. So the answer is not, except the external cardiac pacemakers. But those EMGs, I mean, maybe when I was in residency and we used to go to the ICU because the patient could not be weaned off the ventilator, so they wanted to see how the diaphragm was working, and we did the needle EMG on site right there when they were intubated with ultrasound. But, you know, we never do EMGs on patients that have external cardiac pacemaker. So the answer is yes, we can do safely a nerve conduction study in patients with cardiac pacemakers and defibrillators. So I apologize for the overlapping here. So I did, I kind of like mentioned these two articles. I got a lot of articles that I reviewed to do this lecture. So I like this one. So this is an EMG before and after cervical discectomy. This is an older article from Muscle and Nerve, but you know, I think it's very relevant. So the sample was high, 68 patients. So they did, they measured the H reflex latency and the rate of recovery EMG abnormalities following surgery are unclear. That's what they said. 68 patients with cervical radicular syndromes caused by intervertebral disc lesions. EMG was made shortly before the ACDF and 4 months later. The EMG consisted of the needle EMG and the H reflex for the flexor carpi radialis. So the results were unrelated to findings on needle EMG. The preoperative EMG abnormalities were related to more severe clinical and myelographic findings. Pre-op abnormal H reflex on the flexor carpi radialis correlated with good clinical outcome. No relation was found between the clinical outcome and EMG findings during follow-up. So the termination of the H reflex in the flexor carpi radialis, in the flexor carpi radialis, sorry, I put it wrong here, is useful in EMG tests, but for the comparison to tendon reflexes is necessary. EMG identifies patients with more severe root lesions, but cannot be used for evaluation of persistent complaints within the first half year following surgery. So after reading all these articles, I came with the idea that most likely we're gonna do, and I will discuss it with Dr. McDermott, to include Jovi and our interventional physiatrist prospective cohort study to do EMG findings prior to spinal injections and anterior cervical discectomy. Maybe we'll involve some for the lumbar spine surgeries. And I think we have a lot of patients and we can gather a sample pretty quickly and we can help, we can see if it correlates in our hospital setting. So this is from the epidural injections published in the PMNR in October 2019. So the spinal injections may be beneficial for lumbar spinal stenosis. So past studies showed that interferon gamma, EMG, to predict patients' response to ESI for their spinal pathologies. So they included all these questionnaires for the participants. And at the end, the patients with a positive EMG before spinal injection improved more than the patients with a negative EMG, I would suspect. We're gonna talk about carpal tunnel syndrome and intrapulmonary neuropathies of the most common of the upper extremities and the lower extremities. With time, we have 20 more minutes. How are we with time?
Yes, we have 20 minutes. You're good.
Okay. So carpal tunnel syndrome, the prevalence is 3 to 5% in general populations. In patients with nerve conduction, study evidence of carpal tunnel syndromes in one hand, the contralateral asymptomatic hand will show abnormalities and about 50% of the time. And if they are normal, within a year, they will develop carpal tunnel syndrome. So it's the most frequent compressive focal motoneuropathy seen in the clinical practice. Risk factors: obesity, female sex, decreased cross-sectional area of the carpal tunnel, inflammatory connective tissue diseases, rheumatoid arthritis, amyloidosis, diabetes, hypothyroidism, acromegaly, pregnancy. So the nerve conduction studies are the current reference standard for diagnosis of carpal tunnel syndrome. But also remember that carpal tunnel is a clinical diagnosis. So the EMG, what it would do is quantify the severity to guide the hand specialist to either do a bracing injection or surgical decompression. So the EMG also screens for cervical radiculopathy, ulnar neuropathy, brachial plexopathy, and proximal medial neuropathy. And we have to check for double crush injury in C5, C6 radiculopathy and carpal tunnel syndrome. Remember, The median nerve gives the sensation to the first, second, third, and half of the fourth. And the cervical radiculopathy, C6, is the first and second digits. So sometimes it's very important to do, and I have seen EMGs that the patient had a C5, C6 herniated disc, moderately to severe neuroforaminal narrowing. They undergo an ACDF, they wake up, the symptoms have not improved, they did not have an EMG done, they come to me, I do an EMG, they have a severe carpal tunnel syndrome, they do the decompression, and they improve. So the combined sensory index has been shown to have a greater sensitivity and specificity among the nerve conduction study techniques. So you will see it in my reports. I do ulnar to median comparison to the fourth digit that it has double innervation. I do a median to radial comparison or across the palm comparison. Prolonged median sensory distal latency is usually the first abnormal finding on electrodiagnostic testing, secondary to the damage of the myelin sheath. As carpal tunnel syndrome progresses, prolongation of the median distal motor latency will be noted on the nerve conduction studies. In more severe cases, we will see axonal loss, resulting in a reduction of the median, the SNAP amplitude or the CMAP amplitude, in association with abnormal findings on the needle EMG when we put the needle in the abductor pollicis brevis. In mild cases, there may be an absence of abnormalities with a 15% false negative rate. So ulnar neuropathy and the elbow, and I'm telling you, this year with the pandemic, I've been seeing more ulnar neuropathy at the elbow than carpal tunnel syndrome because the poor ergonomics of people working from home. The incidence of ulnar neuropathy is estimated to be 24.7 per 100,000. It's higher in manual laborers and wheelchair users. It's the second most common peripheral entrapment neuropathy behind the carpal tunnel. Work-related factors include such working with a flexed elbow and holding direct pressure on the ulnar nerve, such as holding a tool in a position. It increases the ulnar nerve neuropathy by 3.5 times. Bilateral involvement is very common. Systemic diseases such as diabetes and rheumatoid arthritis are often associated. Smoking-related work experience and education level were identified as risk factor for developing ulnar nerve entrapment at the elbow that requires surgical treatment. So more accurate measurements with the elbow for the nerve. When we do the nerve conduction study, remember the ulnar nerve is a redundant nerve across the cubital tunnel area. So we should do the nerve conduction studies of the component motor action potential with the elbow flex at 90 degrees. So they record up the adductor digiti minimi. Sometimes ulnar neuropathy is often fascicular. Sometimes we do record it at the first DI to increase sensitivity. So if the ulnar sensory and motor are normal, we should do, as I mentioned before, the first DI. The elbow positioning is very important, between 70 and 90 degrees. This provides the most accurate assessment of true nerve length across the distance. This has been for years. The line of no one. The distance across the elbow should be measured between 10 and 13 centimeters, and this correlates best with the standard of published values to see if there is a decreased velocity across the elbow on nerve stimulation or decreased amplitude. So testing of the contralateral side, it's very important because it can be found in 39% of the cases. Short segments like the inching studies is when we stimulate every centimeter above the elbow, across the elbow, up and below the elbow. It helps in identify the precise location of the entrapment. Dr. Led requests me this test occasionally when she's gonna do an ulnar nerve transposition when the patient has had trauma, especially on the elbow, because we can actually do the inching technique. We can actually see from 1 centimeter to the other a big drop in velocity. So she usually does the incision at that level. I should ask her to do a study with this. I'm gonna ask her, we're gonna do a study with this prognostication of ulnar nerve transposition of the elbow with the inching technique. So slowing the across the elbow segment of the ulnar nerve suggests focal demyelination caused by compression of entrapment and can be used to localize the lesion of the ulnar nerve to the region of the elbow. The presence of atrophy, weakness, claw deformity, and an axon loss detected by EMG texans suggests severe nerve injuries and predicts worse outcomes. Remember the typical benediction sign. So you have to tell the patient to lift their hand and they're like this, like the benediction sign, like how the Pope blesses. So a large review of outcomes suggests that mild neuropathy is more likely to improve with conservative treatment, while moderate severe neuropathy may require surgery. As we have carpal tunnel splints to be worn at night, we have actually ulnar nerve splints. So you can actually, it's like a strap across the elbow, so the patients won't completely bend the elbow at nighttime. It will keep it in a almost a straight position. So duration of symptoms greater or less than 3 months is an early predictor of outcome after surgery, but is not predictive of long-term outcomes after 1 year. So at the wrist, ulnar neuropathy at the wrist. So are the second most common upper limb entrapment neuropathy after the median nerve, and the wrist is the second most common entrapment point of the ulnar nerve after the elbow. So risk factors include occupations, activities, hobbies that can increase pressure at the base of the palm of wrist. Cycling can be identified as an activity associated with ulnar nerve entrapment at the wrist. In older patients that use assisted devices such as standard walker and rolly walkers or four-wheel rollators, they usually like to put pressure on at the wrist, and it's very common to see ulnar nerve entrapment at the wrist. So it is also very important to ensure the adequate fit of any cast, braces, or splints that encompass the wrist to prevent compression of the ulnar nerve. We do sensory nerve conductions should be performed. We should do a nerve that has to be evaluated is the dorsal ulnar cutaneous nerve, because it's the last sensory nerve coming before the ulnar nerve enters into the wrist. So it's useful in differentiating the ulnar nerve entrapment of the wrist between ulnar nerve entrapment of the elbow. It's always very important to do the dorsal ulnar cutaneous nerve. So we do of the ulnar nerve entrapment of the elbow, we do nerve conduction studies on EMG with the recording of the abductor DGT minimi. We do comparisons to the unaffected size. We should be paid to the conduction velocity in the ulnar nerve across the elbow segment to exclude the possibility of an ulnar nerve lesion at the elbow. And it's important to mention here that that's the reason when we see entrapment at the elbow to compare the right and the left, because it could be normal in both sides, but if you see a difference of 50%, it has to be called abnormal. Median motor nerve conduction studies are done also when we do ulnar and vice versa. When we see abnormalities in both median ulnar nerve, we go and do we check for the radial nerve to check for a more systemic neuropathy, more nerve disease, brachial plexopathy, or cervical radiculopathy. So we start investigating. So sometimes as I do the EMG and I find abnormal findings, I add more nerves to the test so we can come up with a diagnosis. Thoracic outlet syndrome. This is one of the favorite diagnoses, the favorite syndromes for Dr. Tolchin. It's thoracic accurate diagnosis on incidence of TOS is difficult to do the absence of reproductively objective measures, 3 to 80 cases per 1,000. Neurogenic thoracic outlet syndrome compromises over 90% of TOS. Venous TOS 3%. The female, an arterial has 1%, less than 1%. Female to male ratio 3.5 to 1. No predilection for the arterial type. The venous, similar in men and women, both usually develop in young adults without significant comorbidities. So we have the scalenus anticus syndrome, the costoclavicular syndrome, and the hyperabduction syndrome. We have the arterial thoracic It has symptoms: limb coldness, pallor, fatigue, claudication with exercise and arm elevation, venous, swelling, edema, cyanosis, subclavian vein thrombosis, sudden onset of limb edema, dusky cyanosis and pain, and neurogenic arm pain. This is the most vague symptoms. Cervical and shoulders pain symptoms. They're mild, intermittent, sometimes increase with exercise. Sometimes they come just with a muscle atrophy and weakness or grip strength. And so the typical electrodiagnostic findings, and I'm gonna go fast over this because we have like 10 more minutes, and I have time. So the median motor nerve conduction study shows a reduced CMAP amplitude and a normal latency. The median sensory is normal. The ulnar motor nerve conduction study, sometimes we can see a decreased CMAP amplitude but normal latency. The ulnar nerve sensory is very important because we see it a reduced sensory amplitude but normal latency. And we see reduced absent CMAP amplitude in the nerve conduction studies in the mixed. So needle EMG, we see signs of denervation, fibrillation, pulsate sharp waves, reduced recruitment, and neurogenic motor unit action potentials in the abductor pollicis brevis, also on our innervated hand muscles, and other C8 and T1 innervated muscles in severe cases. So I'm going to talk quickly about neuralgic amyotrophy or immune-mediated brachial plexopathy. We have had 3 cases. I had a 16-year-old, and we will do it in a future case presentation. We have had 3 cases. So the immune-mediated brachial plexopathy, it's also known as neuralgic amyotrophy. It was described by Parsonage and Turner in 1948, and they named it after them. But now we should call it neuralgic amyotrophy. So some reports showed, so it's characterized by acute severe attacks of neuropathic pain followed by multifocal weakness, atrophy, and sensory changes of the affected shoulder or arm. Some reports show that approximately 15% of the cases occur after immunization or after a viral infection. It's very important, the history and physical of the patient. So it's rare, 2 to 4 per 100,000. It's noted that most recent data suggests that it's not rare. It was thought that it was really not diagnosed. So another study showed that it was 1 in 1,000. The recurrence is 26.1% and as high as 75%. They may involve the same nerves. There are no clinical diagnostic tools to predict or prevent recurrent attacks. There is a 3-2 predominance of men over women. The highest incidence between the 3rd and the 7th decade. The median age is 40. So long-term prognosis is variable depending how much it's involved. Some studies showed less positive outcomes. A large cohort study found that only 10% full recovery after 3 years, and 25% were unable to work due to the NA. A large proportion of the patients have persistent of both neuropathic and musculoskeletal pain, fatigue, impaired activities of daily living, reports of residual paralysis, and exercise intolerance and variable as high as 70% in some studies. So NA, neuralgic amyotrophy, has an acute, subacute, and chronic phase. Hallmarks findings: initial episode of pain followed by weakness. In later stages of NA, sensory disturbance and amyotrophy are seen. The acute phase is characterized by constant and intense sharp pain localized around the shoulder or scapular region related to the portion of the plexus affected. Upper brachial plexus with or without the involvement of the long thoracic nerve is the most common pattern. That's why this diagnosis is like super important to do the rhomboids that are QC5 and the cervical paraspinals. If you're suspecting a cervical amyotrophy and you don't get those needle places there, they're doing it wrong. We had a patient with Dr. Vasquez that had a severe C5, C6 disc herniation, like, you know, from book, blah, 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 but he had a neuralgic amyotrophy. And that patient even had the phrenic nerve involved. He had a paralysis of one of the hemidiaphragm. The subacute phase can occur days to weeks. Often after onset, weakness may develop. Motor deafness predominate. Paresthesia and hypoesthesia can also occur. In the later stages, stable phase, autonomic dysfunctioning can happen. Skin changes, nail changes, edema, temperature, dysregulation, and contractures have been reported. So they develop a complex regional pain syndrome type 2 or reflexive athletic dystrophy. On inspection, physical examination, the weakness, sensory changes. This is the brachial plexus. This is a patient that had a Parsonage-Turner syndrome. So you can see the weakness with atrophy of the deltoid and serratus anterior in the A. In the B, at this time, the patient was unable to abduct the arm to 90 degrees. It's important to remove to completely have the patient naked from the waist up to see any scapular winging, to see if there is involvement of the long thoracic nerve. In addition, the right scapular winging was evident with a 10 to 4 flex. On CD, patient regained full active range of motion by 4 months, and photos taken at 24 months demonstrated complete recovery. In this case, this patient recovered completely. Sensory abnormalities most commonly seen over the deltoid and lateral, indicating upper trunk involvement of the brachial plexus. These incisions may also be present. Reflexes may be absent or normal, and there should be no upper motor neural signs such as hyperreflexor or increased tone. No upper motor neural signs. The imaging is useful, so we have to rule out rotator cuff disease, MRI to rule out a Pancoast tumor. We do MRI of the brachial plexus. A hemidiaphragm can be detected in 10% of the patient, suggesting the phrenic nerve involvement. The electrodiagnostic is most useful to assess in NA. Localization of the lesion in the NA is possible with electrodiagnostic. And the pattern, if we do it, the findings are single or multiple mononeuropathy affecting the suprascapular, long thoracic, phrenic, or axillary nerves. The electrodiagnostic findings can be seen in distribution of the plexus, the upper and the middle plexus, or in combination of peripheral nerves. When sensory abnormalities are involved, the lateral anterior brachial cutaneous nerve is commonly affected, so we have to add it on to the test that we do during the nerve conduction study. The needle EMG demonstrates fibrillations and positive sharp waves and acute denervation with a dive bomber, like all the book sounds and waves. The electrophysiologic evidence suggests that our neural insults are multifocal as well as bilateral, and it helps localize exactly where the lesion is and what nerves are involved. So we're gonna talk about these lower extremity mononeuropathies. So I'm gonna jump. How many more minutes do I have?
I would say we have to wrap it up in the next few minutes to leave time.
Okay, so I'm gonna jump into the fibular nerve entrapment at the, so this is the case would be a patient that comes with foot drop. So we wanna find out if the patient has a deep peroneal nerve entrapment at the knee or a possible L5 radiculopathy. So the common fibular nerve, it's a division of the sciatic nerve, as we all know, wraps around the fibular head, closely adhered to the periosteum, dividing into the deep and superficial fibular nerves. The superficial fibular nerves does the motor to the muscle of the lateral compartment, sensory to the lower 2/3 of the lateral leg and dorsum of the foot, and the fibular nerve, the deep fibular nerve enters the anterior compartment, motor to the muscles anterior compartment. And remember, the deep fibular nerve that innervates the anterior tibialis muscles, the last branch, it's sensory to the first web space. So just with the physical examination, we can diagnose either, if we have the patient walking and we see Trendelenburg gait and foot drop with slapping, we know that the patient has the gluteus muscles involved, so it's an L5 radiculopathy. If it doesn't have a Trendelenburg gait and it has just a foot drop, we have entrapment at the knee most likely. So the most common entrapment is at the fibular head. There is a stretch injury, and actually with Dr. Tolchin, we had a case a couple of days ago that I did EMG on a lady that developed a weakness, not a full foot drop, but she had like a 3/5. And investigated, I said, what do you do? What do you do? What do you do? She lost a lot of weight. She was cycling over 100 miles per week, and she was doing low squattings at the gym, like how the strawberry pickers palsy. She was doing low squatting. So she had it was an interesting case. We're gonna polish it and present it in the future meetings. So runners, ankle sprain, the difibular nerve, it's the anterior compartment syndrome, anterior tarsal tunnel. Superficial inferior nerve is infrequently injured in isolation as it pierces the lateral compartment of crucial fascia, or also seen in chronic exertional compartment. I've been seeing a lot of tarsal tunnel syndrome. The podiatrists have been sending me, and it's actually fairly common. I don't know if because I'm getting a lot of referrals, but you know, it's fairly common. So as we said, you know, we investigate, we have to put the needle EMG. Also a very important muscle to mention here is like the short hair of the biceps femoris is innervated by the common peroneal nerve before it branches. So if we put the needle in the biceps femoris and it's normal, it's entrapment at the fibular head. If it's abnormal, it's an L5 radiculopathy and we go higher. So it's pretty important to do all these muscles when we do a needle EMG to differentiate between L5 radiculopathy and a entrapment of the peroneal nerve at the knee. So the tibial nerve injury is very rare. Thank you.
Excellent job, Dr. Restrepo. I'm taking over for Dr. McDermott. He had to go to the OR, so thank you for a wonderful presentation. We have a couple, in the interest of time, we have a couple of good questions, so I'll read them to you. The first question is, please comment on when to order EMG and nerve conduction studies, or do we need to always order them both together? Should you just be ordering nerve conduction studies or EMG or both? So what's your take on that?
So the American Academy of Neuromuscular Diseases and Electrodiagnostic Medicine recommends that both has to be done. I mean, you cannot do the needle EMG. I mean, unless the patient refuses, it's not a test that is comfortable to do. And it's painful. And we have patients that have had vasovagal responses, and they have passed out with the nerve conduction studies or the needle EMG, but both, we should do both, the needle EMG and the nerve conduction studies. If you're pretty sure that the patient has a carpal tunnel syndrome straightforward, you do a limited where you do 5, and it's a younger patient with no neck pain, you do 5 muscles on each side, 6 muscles on each side, and you don't include the cervical paraspinals, but you should always include the needle part of the test.
Thank you. The next question is, you know, actually related to this, some of these imaging facilities are offering EMG and nerve studies, or by certain clinics like hand surgery clinics, and they buy a machine and they hire a tech to do nerve studies only. The participant was asking whether should you send to those places, or someone like yourself with the, of course, the comprehensive training.
Well, the EMG and nerve conduction study should be interpreted by either a neurologist or a physiatrist. Yeah. I mean, no internal medicine, no family medicine should interpret an EMG because they don't have the qualifications to do it so. Right. As everything in medicine, when you have high reimbursement rate, like in the past, 20 years ago, was for EMGs and nerve conduction studies, in every office, they used to have a nerve conduction study machine, and they used to hire a technician. There is a technician that actually can do the nerve conduction study part, and then the physiatrist or the neurologist comes and evaluates and, you know, reviews and does the needle part. But as physiatrists, we're always educated to do the test on our own. And personally, with how OCD I am, I would lose time, waste time, because I would go and sometimes review what they, review what they did, and most likely I would repeat one or two, so it will be lengthy. But I would, you have to have always the specific. I mean, you're not gonna send, you're not gonna send a family medicine physician to do an appendectomy because they don't have the surgical qualifications.
So you need to know the facility, and it should be a competent neurologist or physiatrist doing that.
Yes, correct.
It should be complete, both EMG and nerve conduct study.
Yes.
In every case. Another question is, please explain for the docs in training what specific information you need on the test order.
So for instance, I mean, for primary care physicians that follow patients with multiple medical problems and multiple comorbidities such as diabetes, for Medicare patients that they do the HEDIS scores, they need sometimes to document that the patient has diabetic peripheral neuropathy. Just mention, can you please do EMG to rule out or to confirm diabetic peripheral neuropathy? It's like a 3-limb EMG. For diabetic neuropathy, we have to do a 3-limb EMG. So we pick and choose both 2 uppers, 1 lower, or 2 lowers, 1 upper. Usually we do 2 lowers, 1 upper because it's more common in the lower extremities. So that's what we do. But it's very important to mention, I mean, in our specialty, the physiatrists know, the neurologists know, the neurosurgeons know. Usually they, what they're looking for. So they say, listen, this patient has a positive MRI, C5, C6, is very symptomatic, the hand surgeon, or we want to, they have numbness in the whole hand. So we want to make sure that they don't have the double crush injury, that they don't have a C5, C6 radiculopathy plus a carpal tunnel syndrome. It happens pretty frequently, as I mentioned. So it's very important for the person that is referring the test to mention what they're looking for. Sports medicine physicians, and athletes that the baseball players, the basketball players that they injured their shoulder, they want to rule out an axillary nerve entrapment, et cetera, et cetera. So to guide the physician that is performing the electrodiagnostics in regards to what they are looking for.
Okay, next question. Thank you. How useful is electrodiagnostic testing for those patients who express that after the vaccine, COVID-19 vaccine, they started to develop upper extremity paresthesias and weakness and are trying to find out if there was a nerve injury or irritation secondary to the vaccination? Have you seen that at all?
I have had 4 cases that Dr. Ouellette sent me, actually. Patients that had the vaccine. They came not with just arm pain, but with generalized upper and lower extremities, sensory changes, neuropathic symptoms like electric shocks down the forearm or the thighs, but I did not find anything on electrodiagnostics. We had a nurse that developed cervical dystonia after the vaccine.
Okay. And then another question is, how useful is electrodiagnostic testing for tarsal tunnel syndrome compared to carpal tunnel syndrome?
For tarsal tunnel and carpal tunnel?
Yes. So tarsal versus carpal, how useful is it for tarsal?
How do I do the tarsal, or how common is it?
How useful is electrodiagnostic testing for tarsal tunnel compared to carpal tunnel? Is it as good?
So remember, we have more or less the same sensory innervation of the feet and hand. So we do the lateral plantar, the medial plantar, and the mixed plantar for a tarsal tunnel syndrome. It's the same principle. We do the ulnar median, and then we do the median ulnar comparison. And then we do the stimulation to see if there is a slowing at the tarsal tunnel.
Okay. And then in terms of radiculopathy and going to surgery, if you have a clear-cut MRI, and I know you presented some data on this, if you have a clear-cut MRI, let's say showing an L4-5 disc herniation, and you have a clear-cut radiculopathy on exam, Do you feel that you need EMG and nerve conduction study prior to surgery? How often are we ordering these prior to surgery?
Well, you know, I did review some articles, and as I mentioned before, the sample of the study was not that big. And as I mentioned, like some of them showed no difference at 1 year, 5 years, but 4 months postoperatively, they showed some differences in regards of the patients that had a positive EMG had a better outcome if they had the surgery than the patients that had a negative EMG. Mm-hmm. I would do, you know, personally, seeing all these cases, I would do an EMG on a patient that they want to do surgery on, because you can kind of mention sometimes with this we see a lot of very complex patients in our practice, and they're going to have complex back surgery. Sometimes the patients have a huge expectation in that they're going to wake up with no pain, and so, you know, I think it's a good idea and a good tool to have the EMG, and I say, listen, your EMG was negative, most likely you're going to improve, but not, you know, you're going to improve not completely, but if the EMG is positive, most likely you can kind of guide the patient, like, listen, your EMG is positive, I think, you know, the surgery is going to be a good tool for you. Same principle for epidural injections.
Okay, and the last question, how many weeks of symptoms should we wait to order the test when a patient has carpal tunnel syndrome or cubital tunnel syndrome? Is it also 3 to 4 weeks, 4 to 6 weeks, like when there's injury, or is it less time?
Well, remember, for entrapments, usually if it's acute entrapment, we can do 3 weeks because the myelin goes first. So we will see slowing or conduction block. So it's more for the radiculopathies that we wait 4 weeks and after, but for entrapment neuropathies, usually 3 to 4 weeks.
And could you just order the EMG portion this person?
Yes, correct. But usually, I mean, for carpal tunnel syndrome, when they are severe, it's important to document that they have signs of denervation, the abductor pollicis brevis, especially for the surgeon, because sometimes the patient think that they're going to fully recover the strength and the muscle is going to come back. And we all know that that's not going to happen. What it's going to prevent is more weakness, and sometimes they recover the sensation. So it's helpful for the surgeon to tell, listen, you have already signs of denervation. What we're going to prevent is more denervation. So most likely you won't recover the full grip or strength, and the sensory changes, and the sensation won't completely improve. So it's a good, the needle in the abductor pollicis brevis when we do carpal tunnel is a very good guiding tool for the hand specialist.
Well, thank you so much. A very comprehensive presentation. There were lots of comments. People enjoyed it and appreciated it. So thank you. And thank you all for participating. And I wish you all a happy weekend.
Thank you very much for having me. I know it was a lot of information. Anyone that wants to come and see an EMG, or you're more than welcome to come. Any questions you have, I'm open. You can email me or call me if you have any questions before setting an EMG.
If you do come, please make sure you look at the brachial plexus before you step in the room with Dr. Restrepo, because he will quiz you, no matter who you are.
Thank you very much for having me. I'm here in Miami Beach. Look at the continuum back there.
Very nice.
The Miami Beach Clinic. It's beautiful.
All right. Have a great day, everyone.
Okay, you too. Bye-bye.
Bye.